Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back to Pod Patrol with your host, Dr. Jeff Dykes.
And Dr. Leland Jaffe.
Thanks for joining us on this episode, everybody. Our viewership and listenership has been skyrocketing. I know that it's easy just to kind of look at the YouTube views and see how many views there are because that's public, but I'm finding that most people are still listening only. Does that surprise you?
Probably not, as I listen to most of my podcasts. Occupying my commute to and from work. So
I do that too. You know, we go to all this extra effort to make the visual component of the podcast with videos and x-rays and all the stuff. And I think that is the most helpful when you view it and can see all that stuff. But I get it. It's much easier to just listen to a podcast on the go, to and from school, to and from residency, to and from work, a few minutes here and there. So we've been going up exponentially.
I mean, those listening are missing out on my Metallica shirt today. So
you're repping the old school. It's funny. Those bands, they don't know anything else and they just keep touring. Metallica is still touring.
Yeah. I mean,
they just keep going. As long as people are showing up. I guess maybe one day they'll show up and there'll be no one there, but then they'll have to stop.
Yeah, I don't think that day will happen. I mean, they play every year, or they played last year at Lollapalooza in downtown Chicago in Grant Park, and it was filled to the brim.
Yeah. So maybe that was a bad example for a band, but there's got to be bands out there that are touring and then they could see their numbers like, hey, we'd like to have you out to our casino. And you're like, okay, well, yeah, casino, sure. Hey, we got a festival. Oh, okay, sounds good. And then eventually someone's like, hey, would you like to play my backyard? And you're like, all right, that's enough. We're done.
Like
Can't go to someone's backyard.
Like a John Mellencamp or something.
Yeah. It's funny. He's popular enough, but there's, one-hit wonder bands that you're like, yeah, I've heard of them, but people aren't going out of the way to go watch them.
No. But yeah, no, now that you mention it, I've seen some bands advertise at the local casinos here in Chicago, like, mid-level bands.
Smashing Pumpkins are coming to West Des Moines soon, so I thought about going to see them. That was my
played at Wrigley Field this summer.
Did they?
Yeah.
They were the very first band that I ever saw when I was 13. I saw Smashing Pumpkins. Yeah.
My first concert was the Rolling Stones.
Wow.
Which I set the bar pretty high.
Yeah. That's hard to top.
Yeah. That was, they played at the old dome where the Rams used to play.
Okay.
Yeah. In hindsight, I think that's where
a big show.
Learned. I learned at a young age what marijuana smells like.
Yep. I was thinking about whether I should mention that or not too at the Smashing Pumpkins concert. That was, it's eye-opening.
My daughter learned that too. We took her to a Dave Matthews concert last summer in Northerly Island in Chicago, and mentioned a few times what that smell was. So
what is that smell? Like,
right.
I don't know. I'm
weird.
not sure. That's weird.
Yeah.
I don't know. I guess we'll never know. You'll never know until college. So, speaking of our growth, we have built a website. podpatrolpodcast.com is up and running. Who should go to the website? Probably like nobody, right? Like, why would they go to the website? But we have a website. It's up. It's official. They should go to your website. What's your website? Tell everybody.
Yeah, so my website is higherlearninghub.com. So I have a link really to all of our podcasts on there too. So there should be a lot of ways that you can go to these archived podcasts if you don't go through the Spotify or Apple Podcast platforms.
HigherLearningHub.com. And what do you do over there? Why should people go to your website?
I have no idea. Well, I
do
try
know why.
to, I'd say I do 3 things on there. Number one is, and everything's free, so you don't have to pay for any of it or subscribe to anything, although that's always encouraged. But first thing I do is I write quizzes. So twice a day I write a usually case study type quiz. The last few weeks I did more like basic science quizzes because our students were taking their part 1 board exam. So I try to make it relevant to maybe what students are studying for. So you can sign up and subscribe, and you'll get an email notification every time a new quiz is posted. I also have a bunch of cheat sheets, things that I thought would be helpful for me to kind of have in my pocket as a student or a resident out on medical rounds. So really high yield stuff that I thought was valuable. And then there's a blog. So we have some guest bloggers, and I write a majority of the blog posts that are centered towards, higher education type topics.
I find those to be really helpful.
Yeah.
Especially for the younger people, because it's kind of a how-to, right? You get a hold of people or you write it, and it's stuff that you don't know that you need to know. It may not be, the clickbait that you're used to online where, some celebrity did something. But you read these blog posts and these articles that you do, and I think they're really helpful for the younger people. So hats off to you for doing all that, because that's a lot of work. I know on our end, doing this podcast is a lot of work. And then you're like, what's the end game? I don't know. It's just kind of fun. So putting it out there, hopefully helping people.
Outlet. Yeah, it's fun. And, there's some pearls I try to throw out there, even for educators too, like how to write a good test question. I mean, no one teaches you that. And, most faculty that work in higher education really have no formal training in how to be a good teacher. So a lot of it's on the job and through mentorship. So this is just another way to, pick up some of those tricks along the way.
Yeah, it's really tough. So
yeah.
What else is going on? I had a post this week that talked about my band from residency. I think we talked about it a little bit. Called ourselves Probe to Bone. So the podiatry themed band Probe to Bone. So we need to get a reunion tour. You probably have never heard us. We were kind of like a low-key indie band. You had to kind of know some people and or have access to our attending's basement in order to hear us. Really is where we were big. Drums.
Nice.
Yeah, just terribly. Keep a beat or something.
Yeah.
Try to do a fill. Sound terrible.
We had a band that played at our diabetes fundraiser last year, which was the first time I've ever played live music, and it was amazing.
Yeah. How long have you been playing guitar?
I've been playing, I played a lot in my adolescent years, and then I really lost it in college and afterwards. And then I honestly picked it up a lot right at the beginning of the pandemic. Had a little extra time in my hands. Yeah. So,
good way to stay busy. I think it happened to a lot of people. I'm going to get into quilting. You know what was big? People were super into, sourdough.
Oh, really?
Like, yeah. My wife was like, oh, we got to get a sourdough. Like, I don't know what about the pandemic spurred people to get into sourdough and baking, but
is that when pickleball got big?
I mean, after COVID, because people were locked up. But yeah, I don't remember pickleball in my past. I grew up playing tennis, racquetball. Yeah. Obviously, no pickleball. So I don't know what the popularity is there. I'm not a pickleball guy, but people love it.
Yeah, it's insane. There's a place when I was in St. Louis called Chicken and Pickles, and it's picture a Top Golf club that is all about pickleball. So it's like a bar / a very social type outing that has pickleball. It was fun.
Yeah, those are fun. We have a place like that here called Smash Park, and they're fun. I don't like it. I'm not gonna like do my sporting activity and drink at the same time, like except for golf. Golf is different.
Yeah, I mean pickleball is a little too aerobic exercise to drink beer while you're playing pickleball.
Yeah. And then you got it in your hand, and then the ball, and then the paddle. It's just too much going on. You got to set your beer down to pick the ball. Now, I'm out. This week, this past weekend, Ashley and I played glow ball. We did a Twilight Golf glow ball. So the balls glow in the dark. So it's pitch black. You're driving around. We got the tunes blasting, and you're playing with a glow in the dark golf ball. So you're driving the cart, trying not to hit trees, trying not to drive through the bunker. It was a blast. It was absolutely awesome.
Was it a full course or like a par 3 course?
It's a full course, but they turned it into a par 3 course where they put a little glow stick, a little solar lantern in the middle of the fairway on the longer ones, and you hit from there. Nice. So it was so fun. Yeah, it was a good time. So highly recommended. If you ever get the chance to do glow ball night golf, do it.
Yeah.
You ready to jump into our topic today? We're going to talk about Jones fractures.
Yeah, that's a great topic. I think definitely one that anyone in practice probably sees quite often. So hopefully we'll pick up some pearls and talk about some high yield things along the way here. Do you get a lot of Jones fractures in your practice? I imagine you do.
I end up seeing these quite a bit. I see a lot of fifth metatarsal fracture. So it's interesting just the pathomechanics of how these develop. It's a super common injury, far more common than a first metatarsal fracture, which makes sense. The mechanism is quite different, and the first metatarsal morphology is quite a larger bone, more difficult to injure. But see a lot of fifth metatarsal fractures, whether it be styloid process avulsion fractures, Jones fractures, shaft fractures, neck fractures, all the above. But today we're going to specifically talk about Jones fractures. So this is an interesting case. It's a 64-year-old male who trod on the outside of his foot whilst dancing with his heel off of the ground. And if you don't recognize that, that means that you have not read the original Sir Robert Jones paper from 1902. And these are his exact words when he sustained this exact fracture to his foot, and henceforth has been called the Jones fracture. So
love that.
So this is a true case study from 1902, and he wrote a paper about it. And since then, we've been calling it the Jones fracture. So it's kind of an interesting fracture. So, very, very common. I think it's typical for these to get misread. People don't really understand. They call every fifth metatarsal fracture a Jones fracture. Oh, that's a Jones fracture. Jones fracture. Right. I look at it, I'm like, nope, not even close. Stop it. So obviously we and anybody listening to this podcast is going to know what a Jones fracture is, but I do see them commonly misdiagnosed. I'll have someone contact me like, hey, I got a Jones fracture. And I think, oh, okay. Let me take a look. And then I look at it, I'm like, oh, well, that's not a Jones fracture. So let's dive a little deeper into where this Jones fracture is. So Sir Robert Jones, this is him looking good with the bow tie and the mustache, pulling off a pretty good look there. So when we're looking at these Jones fractures, we could break it down into specific areas, and everyone knows this, but let's talk about it because there's a couple ways that I teach the students to identify what a Jones fracture is and what's not a Jones fracture. So the very, very most proximal aspect of that styloid process is going to be an avulsion injury. Now, that could incorporate the entire tuberosity, or if it's pediatric, we're looking to involve the apophysis. So pediatric fractures of the fifth metatarsal base are a little tricky because you look at that apophysis, the growth plate, and you can get fooled a little bit because I've seen some that get read as a fracture, and I look at them like, no, that's the growth plate. But I have seen some abnormalities to the growth plate, including avulsion of the growth plate with proximal translation with increased gapping of the apophysis at the fifth metatarsal. So in that case, typically you get a contralateral extremity and see what's normal for them. And you can look to see if that's their normal or if they do have some increased gapping at the apophysis, which becomes a Salter-Harris type 1, a growth plate injury. Some people are born with that accessory ossicle back there, and that can get confused with a fracture, especially not us, but some other people may confuse that for a fracture and send them to you. So let's exclude the accessory ossicle and the apophysis for a minute and move on to the three kind of zones of the proximal fifth metatarsal fracture. So we have the tuberosity, the styloid process, or avulsion mechanism that's really at the most proximal aspect of the fifth metatarsal. And as we go distal, we have the proximal diaphysis, so the mid shaft of the of the fifth metatarsal. That can be an acute injury. It says here stress fracture, and that is a common spot for stress injury, but it can be an acute injury. I've seen them in that area. They tend to not be as transverse in that area. As soon as you start to go distal, they start to be more of an oblique injury in my experience, more like the difference between a Weber B fibula where it's kind of straight across, or a Weber C where it starts to get that obliquity, maybe, or a spiral nature of it. And that just depends on how the forces move through the bone, whether it breaks in a transverse fashion or whether it breaks in more of an obliquity type fracture. So, and in between those two areas is the Jones fracture, the metaphysis area of the fifth metatarsal. So if I go back to this previous slide, the way that I teach students is if you look at the articulation, typically on an AP or even like in this case, an oblique, and you look at the articulation between the fourth and fifth metatarsal bases, that to me is Jones fracture. So anywhere right through here, right at that proximal articulation where the fourth and fifth metatarsal bases overlap, straight across all the way to the lateral cortex. And as we move distal, it's the same. It's the fourth and fifth overlap right through here, straight across. So anything that kind of encompasses the area where the fourth and fifth metatarsal bases have that overlap, or even form a little articulation in there just distal to the cuboid, I would call a Jones fracture. What do you think about that?
Yeah, no, first of all, I'm glad you said oblique and not oblique. I'm not an oblique kind of guy.
No, I'm not. No skeletal. No, nothing weird. No.
But I might be adding trod to my lexicon and my word choice. So
and whilst dancing,
I don't know if I can get on. That's too many consonants in a row for me, but
it's just a little elevated way to speak. Just take it up a little notch.
No. I can appreciate that. I agree. I mean, in terms of a true Jones fracture at that proximal diaphyseal metaphyseal junction, which is right at that level where you're describing, I think the way you described it gives the audience a little better visualization of how to identify it on an X-ray versus more just academically understanding that it's at that junction. So I think those landmarks are helpful for them to identify the true Jones fracture.
There are times where you might get tricked a little bit. And if you're waiting for the growth plate to heal in the time it takes a fracture to heal, you will be waiting a very long time. Mm-hmm. Then you will diagnose a non-union, and then you will look very dumb when you realize that that is a growth plate and not a fracture. So knowing the difference between those is very important.
Absolutely.
So let's jump ahead to treatment options, because this is where I think that you can kind of go in a bunch of different directions. So these are all visual pictures of different fixation options for fifth metatarsal fractures. Now, typically I use more of a hook plate construct with the avulsion injury, and I typically do not fix those. Most of the time those will heal. If they have a significant amount of proximal migration of the fracture, if there's a lot of plantar gapping, I see that a lot where the fracture is actually, it looks okay on an AP, and then you check the lateral and you zoom in, you look really close, there's a lot of plantar gapping. I know that those are going to take a long time to heal because they don't tend to hurt that much. Sometimes I will go in and fix a proximal fifth metatarsal fracture like a styloprocess or an avulsion injury. And for that, I will use a hook plate. So one of these constructs that has the two little tines, they go into the fifth metatarsal base. You kind of suck it down with either some eccentric drilling or just manual compression, or sometimes a screw through there. I don't love to throw that screw from the proximal component of the fifth metatarsal base styloprocess down the shaft with the plate, because that fracture tends to be very small and you run the risk of secondarily fracturing that fragment. So you have the transverse fracture that is the styloprocess fracture, and if you drill and throw a screw down that very small piece, you run the risk of creating a sagittal split fracture. So I just don't find it necessary. I think with the hook plate, you can get it on there, suck it down, and either eccentrically drill or just manually compress and realign those. So let's move on from those and talk more about the screw fixation.
Yeah. And I think a point to bring up is, and I agree with you completely, avulsion fractures usually are going to be non-surgical. Similar to like a dancer's fracture distally, a lot of those can heal just with a similar Cam Walker type partial weight bearing protocol.
Right.
But one of the things to think about with a Jones fracture when we talk about treatment, we have, for those of you that are listening, there's basically 4 images of screws and plates. But just to kind of bring up the bigger question of surgery or non-surgical treatment, and I've come into a few situations with Jones fractures where it was a little bit counterintuitive, where surgery was actually the less invasive treatment. For example, we had a patient who was, gosh, maybe 10 days postpartum and had a Jones fracture. And even the thought of being non-weight bearing for 4 to 6 weeks was impossible with a newborn at home. So much easier just to schedule a surgical procedure, and then she could weight bear as tolerated in a cam walker, right?
Yeah, and I end up doing that a lot also with my elderly ankle fracture. So same reasoning, right? Even if it's a distal fibula fracture, even if you think it's stable, these people can't ambulate in a boot. They walk with a walker at baseline. They're going to trip and fall with this boot. And so in my mind, it's better to throw a fibular nail or even an open procedure sometimes, because I can do it so quickly and just get it open, close, fix, stabilize. Then I say, yeah, you can walk on this. Maybe I'll put you in an ASO brace or something to stabilize, but we're going to get you walking a lot sooner. I don't trust these people. I've had some people that were supposed to be wearing a boot. They didn't wear the boot. Maybe they were neuropathic, whatever. There's a million different, scenarios out there. Every patient is different, and they walk on it and it displaces. And now it's a train wreck. Now it's an absolute nightmare. And it's so much easier. Selfishly, it's so much easier for me to just do 15 minutes of surgery, 20 minutes of surgery, get in, be done. Yep, you can walk on it. The chance of that migrating or displacing or worsening is much lower. So we'll talk about that a little bit more in a little bit, the surgery versus no surgery. But I agree with you that we have to treat every patient individually. It sounds cliche, sounds stupid to say that, but when you see enough patients, everyone has a different scenario. I live at home. I'm in a nursing facility. I have nobody at home. I have lots of people at home. I'm ambulatory, but I'm 89 and I put my own shoes and socks on, no problem. Everyone is a little bit different in terms of their functional status and comorbidities. So I think that's a good point you bring up. So here, when we're talking about single screw fixation, we're talking about intermedullary fixation down the shaft of the 5th metatarsal across the fracture. So typically you're going to use a solid screw construct. So they do have some cannulated screw constructs like the one on the top left. I don't trust those as much as a solid screw. I don't think we should be putting in cannulated fixation. Say that again.
I said agreed.
Yeah. So, and we'll talk about that more in a little bit too. So the one on the bottom there has like this little, I think they call it a nipple, like this little pin tip that helps find the hole, because what you're going to be doing, and we'll talk more about this in depth here in a minute, is doing a cannulated technique with a solid screw. You're going to be doing everything cannulated, but then at the very end, you're going to pull everything out. So if you do a cannulated screw, you leave the wire in, you put the screw over the wire, you insert it, and easy peasy, you're all done. But when you pull everything out, sometimes you can have difficulty finding that hole again. I have seen people, luckily not me, put the screw in and miss their hole. They put the screw in, they did everything perfectly. Their wire was down the shaft, the drill was down the shaft, and then since everything comes out and you're relying on finding that hole again, it's not that crazy that people will sometimes just start putting the screw in and be either superior or lateral to the 5th metatarsal. Anyways, don't do that. So let's dive a little deeper into drills, taps, screws, and all the information here, because this is pretty standard across most sets. The original set that came out, I believe, was Wright Medical, had the Carolina screw. It was invented in Carolina, so they called it the Carolina screw. And they originally had the 4.5, the 5.5, and the 6.5. Well, over time, they realized that nobody was using the 6.5. It was way too big. You'd blow apart the 5th metatarsal, unless it was just a gigantic person with a gigantic medullary canal. So now, almost all the sets that have single screw fixation are going to be 4.5, 5.5, or 6.0 millimeter screws. So we start with a K-wire. K-wire goes down the shaft, 3.5 millimeter cannulated drill that goes over top of the wire. You pull that out, and then you're going to start tapping. They recommend that you start with a 4-5 tap, move to a 5-5, and see if you need the 6. I don't do that. I go right to the 5-5. You do enough of them. You can look at the medullary canal, and you can look at it and be like, oh, that's a 5-5. Just give me the 5-5 tap. And then I'm going to just go ahead and put a 5-5 screw in. The most common screw that I put in 95% of the time is a 5.5 millimeter screw, 55 millimeter length. Now, they'll say that the most common length is 50, but it's going to be somewhere around there, 45, 50, 55, maybe a 60. You got to be a little careful when you go long, because some people have that normal curvature of the fifth metatarsal, and a straight screw will not follow a bending medullary canal.
Right.
At least a solid screw won't. A cannulated screw will, and that's part of the reason I don't favor cannulated screws, because the screw's already bent following the medullary canal, because it's just intrinsically weaker and more bendable than a solid screw. But you have to be careful going long, because you're going to violate that medial cortex of the fifth metatarsal. Back in residency, I will not say who. I watched someone, not an attending, put a fifth metatarsal screw in that they kept screwing it in too much, and it penetrated through the medial cortex of the fifth metatarsal, and then the threads had advanced so far that then when you tried to back the screw out, it had no bite in the bone. So it had advanced too far through the metatarsal and then out through the medial cortex. And the only way they could get that out was to keep advancing the screw, keep going, push, and pulled it out through the fourth and fifth intermetatarsal space.
Ooh, that's not ideal.
Yeah, I mean, it's good to see, because then you're like, all right, so how did that happen? Let's make sure we don't do that anymore. So for every time you see a perfect case, you probably end up learning more from a case that doesn't go smoothly. So
100%.
When you do that and figuring out, okay, well, how am I going to get this out of there? I can't back it out. It's an improper placement. How am I going to get that out of there? So seeing things like that is actually helpful. You ever seen a fifth metatarsal fracture surgery go wrong?
Not like that. I have not seen that complication. I was going to say, a lot of times beforehand, with digital X-ray being, fairly ubiquitous everywhere. I mean, I tend to know the medullary width and the length of the screw that I'm going to be using preoperatively. You can certainly confirm it intraoperatively by measuring, but you should know ahead of time pretty much what screw you're going to be using, just with good surgical prep. But with these kind of cases, really, I think what makes or breaks the case is getting your K-wire positioned easily. Because what I see more often is on the K-wire position, you'll look perfect on the AP view and get the lateral, and then you're under the bone, right? Then you pull it out and get it good on the lateral, and then you're coming out the medial cortex on the AP, right? So really just making sure that you get that wire positioned appropriately. With, for those watching on YouTube, you'll be able to see the outline of the fifth metatarsal. But yeah, really just outlining, using your fluoroscopy to outline everything before you position the wire can really be helpful.
The two most important parts of this entire surgery are patient positioning, number 1, and wire position, number 2. If you position the patient perfectly and you throw your wire perfectly, the case is over. We're done.
Should be 10 minutes or less.
Yeah, very, very reasonable. I believe I hold the world record at 5 minutes. If anyone has beaten 5 minutes, well, keep it to yourself, because I want to still think that I have the record. So 5 minutes is my record. And I have that all on video on my social channels, because, why not? But finding that wire placement is the most important part of the procedure. So we'll talk about that more in a minute. So this is the single screw fixation for the Jones fracture. There's a lot of variability when you throw these screws. Sometimes it compresses really well. Sometimes I've had them almost kind of like slide at the fracture site a little bit if you're getting compression, because you think that you're putting complete axial compression down the fifth metatarsal, but you can't have 100% axial compression into a curved structure. You just can't, because the bone starts this way and then it curves with the base, and then it starts to go down the shaft, and then it curves the other way. So you're throwing a straight object down the center of a curved object. sometimes you're going to get some translation of that fracture, and that's okay. Just pay attention to that, and you could tolerate that. I mean, if it's a 1 millimeter little kind of step off there after you compress across the fracture, I've never had a problem with that. But just be aware of that. When you compress across the fracture, you think that you're 100% axial, but it's almost impossible to be 100% straight compression through a curved object. So I thought this was an interesting article for us to talk through. It's out of Foot and Ankle International, March 2024, called Clinical and Radiographic Healing of Non-Operative and Operative Treatment of Jones Fracture. So they had 166 fractures that were Jones fractures, and they compared the operative versus the non-operative healing rate. And what they found was that there were no differences between non-operative and operative groups in time to clinical healing or radiographic healing. Overall healing rate was 96% for the non-operative group compared with 96.2% for the operative group. So typically, we've always been taught that Jones fractures are a surgical problem. What I take away from this study almost verifies that to me. You think, oh, the healing rate's the same in both. But keep in mind, this is a retrospective analysis. This is not a double-blinded study. We're not randomly putting people into two different groups and seeing what the outcomes are. These patients have been purposefully self-selected because it's a retrospective review. They took certain people. Oh, this one's going to be a little slower to heal. I'm going to do surgery on this one. This one has comorbidities. I'm going to pick this one to do surgery on. You're self-selecting the patients that you're doing surgery on, and that's going to skew your overall results. Now, I will say that having the healing rate to be equal between those groups was a little bit surprising to me. What do you think about that?
Yeah, no, I agree. I think if you just read the highlighted portion saying that the healing rates are equivalent, you might come away thinking, well, I should probably stop operating on my Jones fractures.
Yeah.
However, I think as we talked about earlier, this doesn't take into consideration the points that you made, as well as some of those social determinants of health in terms of, my patient that takes 2 buses to get to my clinic for follow-up is not going to be able to stay non-weight bearing, right? So that individual likely is going to need, surgical care to stabilize this fracture so it doesn't go on to a delayed or non-union after, 6+ weeks of trying to heal this. So there's a lot of other factors that play a role here. So yeah, if you get a patient who's got a support system at home and an ability to maintain, that non-weight bearing status, I would imagine that you'd be able to get an equivalent healing rate, as most Jones fractures are fairly well aligned with minimal displacement, right? So the healing potential should be there, but I think there's a lot of other factors that come into play here.
Yeah, I think the other thing that's interesting about this study is that if you look at the time to healing in the two groups, it was between 12 and 13 weeks for both, for clinical healing and radiographic healing. I'm so used to telling patients, they're like, oh, how long is this going to take to heal? And I'll say, well, bone will start healing at 6 to 8 weeks. And then they get it in their head that they're going to be dancing. They're going to be trotting on their foot whilst dancing.
Yes.
6 to 8 weeks after the injury. And maybe, but this is interesting because this is 12 to 13 weeks. That's almost double what I'm telling my patients. What do you tell patients when they ask how long it's going to take to heal?
Same thing, 6 weeks plus or minus. I always say, the body's physiology, you can't speed that up, right? It takes about 4 to 6 weeks for bone to heal. But, I think we know that usually radiographic signs of osseous healing is a little bit lagging behind clinical healing. Mm-hmm. So, I mean, once their symptoms go away, even if I still see some evidence radiographically that there's healing still occurring, I'll tend to advance them accordingly.
Yeah, I think, when we get caught up on these numbers, you keep in mind that we're really comparing operative versus non-operative. And if you think about the non-operative group taking 13 weeks to heal, letting my surgical patients walk on this way before that is probably a benefit to the surgical patients, like you just mentioned. So keep that in mind as well, because the clinical healing is it's the same. Radiographic healing, it's the same, but I'm going to let patients walk a lot sooner with that intermedullary screw down there. I had a guy one time, he must have been 450 pounds, super nice guy, just gigantic. He could not stay off of his foot. Like he just physically just could not stay off of his foot, and the screw was fine. He was walking on it, and from day one after surgery, and the screw was fine and it healed just fine. And he was gigantic and putting tons of pressure on this thing, and it was fine. Now, if he didn't have a screw in there, I'd be thinking, man, this is never going to heal. You're putting a lot of pressure on this. Micro motion at the fracture is, sometimes a good thing depending on what circles you run in terms of healing modalities, and micro motion at the fracture and dynamic stability of plates and screws and all that stuff. But I felt a whole lot better having a screw in there because this guy couldn't stay off of it. So interesting study that at first glance you think, oh, well, maybe we don't need to do surgery. I still think there's a very important place for surgical fixation of these Jones fractures. So this is my surgical technique here. So lateral positioning, I'd have the patient lateral with a bean bag. If anyone that doesn't know what a bean bag is, it's a giant bag full of beans. I don't know what it's full of. And you lay it under the patient, and then you kind of roll the patient sideways, like if they were sleeping on their side, put a pillow under their arm, put a pillow between their knees for comfort, and then fold the arms of the beanbag up, and then use the suction device to pull the air out of it. And then it basically freezes in place. It holds them from tipping forwards or backwards. So you put them lateral on a beanbag, and then I always ask for about 7 or 8 blankets. So this patient right here is lateral on their side with a beanbag, and their front foot is forward. So picture, in this case, the right side is the operative foot. Their left leg is completely straight. Why? Because when I take an x-ray, I don't want their other foot to be under my foot that I'm operating on. I want it completely separate. The left leg is completely straight, and the right leg is bent and resting on about 6 or 7 blankets there. How do you position your patient?
Yeah, lateral position is going to be much easier. I'd say the positioning is pretty similar. Question for you is, what's your decision between the big C versus mini?
I hate the mini C arm.
Okay.
I don't have 5 hands.
Yeah.
So I'm by myself. Well, that's not true. I have students, but they're 3rd-year students, and I'm not expecting them to have any grad. This is probably the first time they've been in the ORs with me. So I'm not expecting them to be overly helpful. So I need the C arm to just be positioned AP, lateral, oblique, calc axial. Right. I just tell them, and I'm doing all the work, and they're just firing photos.
Got it.
Do you use a mini C arm?
Yeah, sometimes I find I would say half of my cases I have a colleague with me sometimes, and then a student. Yeah. So it's a little bit easier sometimes for positioning from that standpoint.
Sure. So me is just usually me and the student and the scrub tech. So I just don't want to have to mess with that. So here we're marking out the 5th metatarsal. I use a K-wire, and I will mark out the 5th metatarsal, superior surface, inferior surface, proximal aspect, draw out the 5th metatarsal. Then I make my incision just proximal to that. You can see here on the left. And then we're starting the guide wire down the shaft of the 5th metatarsal. They always say high and tight. What does that mean? Basically, it means kind of hug the cuboid and go a little bit more superior than you think. And you're going to find the best starting spot is not at the tip of the styloid process. It's actually a little more closer to the cuboid, so that when you go down the medullary canal, it doesn't have to turn as much of a corner. So this is the wire here, and then you're inserting the drill over top. We learned before that's a 6.2 K-wire, I think, with a 3.5 millimeter drill. Cannulated technique or tapping. Remember, I skipped the 4-5 tap, jump right to the 5-5 tap. I don't even measure anymore. I just say, give me a 55, or I can look at it and say, but it starts to bow or bend a little sooner, and give me a 50. Put the screw in there. Try not to advance it so far that you have to stick it out the end of in the 4th metatarsal space. So this is me. This is my case here. We can kind of watch through this and see if you do anything different. So I open up that incision, spread with a curved hemostat, get access to the 5th metatarsal base. So this is actually the case that I did in 5 minutes. My tourniquet time said 6, but the rep who was stopwatching clocked it at, I think, 5:53. So even though the tourniquet time said 6, I'm still counting that as 5. So here we are drilling. What were you going to say?
I said that sounds fair.
Yeah, I'm going to claim it. So we're drilling down the shaft. You don't really have to drill very far. You just drill past the fracture line, and that's fine in my experience. You don't have to drill all the way. And then tap. So in this case, I don't know how you were taught, but you're tapping until you see the foot start to move. Mm-hmm. And then you know that it's the threads are engaging the cortex. So when you tap and the foot starts to move, and in this case, you could see I'm putting the screw in there. You see the foot start to move even when you're not holding it. That means the threads are engaging the
you see the foot
cortex of the bone.
A little bit. You see like a little toggle.
You see that start to move. So here it is. Great success. Screws down the middle. Take another picture. Great success. Fifth metatarsal fixed. Tourniquet time 6 minutes. Then we celebrate. I thought it was 6, but I'm counting 5. All right. Do you do any of that differently?
No, I think that's pretty. I think I the only thing I would do differently is probably at least double the tourniquet time.
Yeah,
definitely.
I mean, 20 minutes is very reasonable. Assuming everything goes smoothly. So a couple of techniques. So this is my team here. We're celebrating 5 minute.
You're like they
have no idea.
You're like the Usain Bolt of Jones fractures here.
Yeah. Okay. So I do have to say something. My wife made me promise that I would say into the microphone that speed does not equal excellence. Just because you do it quickly does not mean you did a good job. Now, I argued just because you do it quickly doesn't mean I did a bad job. The screw looks perfect to me. I wouldn't take 20 more minutes and make it any different. So just because it happened quickly doesn't mean that it's a bad job. So don't rush. There's no really reason to rush. And if you watch the entire video of me doing this, I was not rushing. I was not trying to go as fast as possible. That's not fair to the patient. But if you throw that wire, you get it on the first try, you check 2 views, the wire's down the shaft, you're pretty much done. You're going to drill, tap, screw, done. It's very simple.
2-3 stitches at the end. I mean, that's the whole case is getting your wire positioned correctly.
Yeah, very, very reasonable. So let's talk a little bit about what not to do here. So when you look at that x-ray, what can you see? So we're looking at an oblique and a lateral, 2 bad obliques of a foot that has some fixation in the 5th metatarsal. So what do you see there that could have been done better?
Yeah, I mean, looking at the screw here, it looks like it's a small screw. I don't know the size of the
very
screw.
Very small. Yeah, that's small. Like a 2730 maybe. Not a 5, not a 4.5, not a 5.5.
Yeah,
but it's like a 2.7 or 3.0.
It looks cannulated.
It's cannulated. It is cannulated, and it's got a washer on it because they used way too small of a screw, and so they tried to displace some of the forces. And even with that, they penetrated way too deep. They put the screw in too far that now you're never going to get the screw out because it broke. But you were really going to struggle to get that screw out anyways because you buried that head deep in there with a washer. Yeah, good luck to you. That's in there.
That's a tough one.
So this is just to give full credit here. This is an article called 5th Metatarsal Fractures, an update on management, complications and outcomes from 2022 January. I think that we can learn some things here from what I'm sure they didn't do this. They're not going to create a journal article and be like, hey, look how terrible we did. They're going to find other, people following up. But making sure that you follow the standard protocol here is important, just like with any surgery. So instead of using this cannulated screw, you want to use a solid screw. Instead of using a tiny screw, you want to use the appropriately sized screw. Even if they used a 4.5 screw, it probably would, a 4.5 solid screw, this wouldn't have broken. Even if it was technically too small for the bone, it would not have, I could guarantee it would not have broken. I've never seen a solid 5th metatarsal fracture screw break. Have you seen that?
No, I mean, I think the company I tend to use, I saw a ad of I think it was a power lifter doing like deadlifts with them in their foot. And I'm like, all right, that's this thing will hold up fine.
Yeah,
so
exactly.
No. Yeah.
So you got to keep in mind that, just because you're putting a screw across it doesn't mean you're fixing it appropriately. So I'm sure everyone listening is like, yeah, we know that. Of course, I would never do this, but someone did this. So don't be that person. Don't Don't put a cannulated screw in. Don't put a too small of a screw in. It's going to be subjective to too much bending force along the fifth ray, along the lateral column. There's just too much force there. Could you get away with this in maybe a central metatarsal, even though you're not going to be doing an intramedullary technique? I understand that. But could you get by with using smaller screws in a central metatarsal? Yeah, sure. We do it all the time. But through the fifth metatarsal, it's just not a good procedure selection and not a good outcome.
Yeah, no, it looks like a screw that almost would be used for like a digital arthrodesis or something like that.
Anything you'd like to add to this?
No, I mean, I think another topic we could talk about that extends a little bit beyond what we want to cover during this podcast is really, expand on the complications part, right? Because some of us are going to see perhaps ones that are fixed well and still developed a non-union, or and that's a tough complication to manage. So talking through surgical treatment options and bone grafting options, and fixation is going to change a little bit once there's a non-union. So I think we should.
So let's talk through that real quick, because I don't know if it warrants a whole episode on that. I mean, we could do certainly a whole episode on non-unions and bone grafting and all that stuff. But let's say someone comes in with a fifth metatarsal Jones fracture fixed appropriately, and it still went on to non-union, and it happens. What is your workup for the patient, and what are your treatment algorithms, and what's your plan?
Well, that's a lot to unpack.
And you have 10 seconds. Go.
Yeah. So, all right. I mean, I guess at first you want to identify what went wrong. Why did they get a non-union? Was it procedure mistake? Was it compliancy issues? Was it just intrinsic to the patient, right? Are there vitamin D issues? Is there
vitamin D deficiency
issues, right? So I think you kind of have to look at the patient holistically and figure out like where was there an issue, so we don't have the same problem the second time.
Yeah.
So typically what will likely be needed is to remove whatever hardware is in there. Do a little bit more of an open approach where you're debriding out the bone. And I know there's a lot of different types of non-union, but assuming we have more of like sclerotic bone edges that have no capacity towards healing, those need to be debrided and resected, and likely using some type of tricortical bone graft from a structural standpoint, maybe from the calcaneus, or if you have the option to get iliac crest from orthopedics, like that'd be helpful as well too.
Yeah, I think it depends on how long after surgery we're classifying non-union. So my workup is check their vitamin D level. Almost always it's low. If someone gets, I always tell people they're a self-selected population. You could say, I check all these vitamin D levels and they're so low. Everyone's low. Well, no, they're not. There's a reason you're checking the vitamin D, and it's a certain subsect of population that warranted you checking their vitamin D, which means you're more likely to find deficiency in the patients that you're selecting to order the vitamin D. Anyways, once you get the vitamin D, if it's low, I give them a fair chance to heal. I'll treat with 50,000 international units of vitamin D weekly for 8 weeks and then recheck. I don't always recheck. Recently, they changed the law They changed the insurance reimbursement to be approved for a vitamin D level once per year that it's covered. So if you have vitamin, even with deficiency, which is crazy to me, because then how should I never check it again or what? But anyways, if they have deficiency and then I treat it and they were kind of borderline, I don't necessarily check it again, because I assume that they've now bumped up into the normal level. I've been treating this for enough years. 8 weeks of 50,000 international units generally bumps up anywhere between 3 to 9 or 10 on their number. So if they start at 16, I've seen a 12 one time, and low is 30. I am going to probably going to treat for another 8 weeks, and then I am going to recheck, because I'm not going to give up until I know they're in the normal level.
Yeah.
But at that point, yeah, go ahead.
I was going to say, I think, looking at just from a value standpoint, normal ranges do vary a little bit based on institution, because I see sometimes 20 to 50 being normal range, and then 30 to 50 being normal range. But
so they did switch it. I don't know who switched it. The American Association of Family Practice or Rheumatology. I don't know who's in charge of all that, but they did switch it from 20 to 30 as the low level of normal, which I completely agree with. I've checked how many, who knows, vitamin D levels. And I do see non-union happen in the 20s all the way up into the low 30s. I'll see non-union. So if I see a 32, a 34, a 36, I'm treating, because I don't know if I've ever seen, I've seen 80s. I think I saw over 100 one time in my whole life. So, and they don't bump up very high when you treat them. So, even if they're low, quote unquote, normal, I will treat them. And then I will give a bone stimulator a chance. If I know that their vitamin D level is normal, I know they don't smoke, try to, whatever, diabetes is hard. If they can control their sugars, great. But then I will order bone stimulators. Do you order bone stimulators?
Yeah, again, I think it depends on the type of non-union. And again, not to get too academic, but there's different types of non-unions, and ones that really have no capacity towards healing, I usually won't. But if the patient does have a chance, I think it's a good idea to add some kind of ultrasound or electrical bone stim.
Yeah, if you see that atrophic, if you see that kind of sclerotic bone at the fracture site,
exactly,
you have very low likelihood that that's going to heal with any kind of vitamin D treatment or bone stimulation. You're looking at doing revisional surgery. I agree with you. I would take the screw out. Hopefully it doesn't look like that last one that was broken, because that's going to be a nightmare trying to get that out of there. I'm going to do a wide excision of the fracture ends. I'm going to stimulate subchondral bleeding by drilling down each side of the non-union fracture. I'm going to harvest a plug from the lateral calcaneal wall 1 millimeter larger than the defect that I drilled out. If you go back and listen to my episode with Dr. Des Moines, he describes that technique in good detail for a metatarsal base, second metatarsal, I think, non-union. You pull out a plug slightly larger, you press fit it into the defect, and you cover it with a plate. So that has worked well in the past, but you have to double check a lot of things before you just go back in and start fixing again, because there's a reason it didn't heal in the first place.
Exactly.
And to just go back in and assume that it's going to heal, you have to fix the vitamin D. You have to talk to the patient about staying off of it. You have to tell them, hey, I know you're still smoking. I can smell it. You got to stop smoking. This is never going to heal, right? You got to have some hard conversations and get in there before you just jump to revisional surgery. I think that's important.
Yeah. And to even go further on the vitamin D thing, try to figure out why they're deficient, because it could be, it could be dietary. It could be because we live in a high latitude, but it also could be they have underlying chronic kidney disease and they're not activating vitamin D, and they're getting renal osteodystrophy, which creates a similar problem. So that requires a little bit more interdisciplinary type workup and management of your patient.
And we did not even involve the likelihood of metatarsus adductus and cavus foot deformity in the development of fifth metatarsal fractures in the first place. So I have an article. You can Google my last name and look up an article about the association of metatarsus adductus with the development of fifth metatarsal fractures and the delayed healing that those are subjected to. Just because there's so much lateralization of the forces when they're walking right at the fifth metatarsal base, they're prone to development, because they usually have some sort of stress component that devolves into an acute fracture if the bone gets weak enough, and then they're less likely to heal. So structural evaluation as well with cavus foot deformity and consideration of reconstruction. That's not crazy. If you're doing revisional surgery anyways, and you're just going to go back and try to fix the same fracture in the same cavus foot with the same lateral column overloading, you might be doomed for failure again. So taking a step back and evaluating all the factors at play is important.
Yeah. Consider, your Dwyer, your lateral calcaneal slides, things like that, just to alter those ground reactive forces. I think that's an important point. It's a good point.
Yep, absolutely. So I think we'll leave it off there. I think we've covered Jones fractures in detail. This will be a good kind of review for some people, and probably a whole lot of new information for a lot of our listeners. So awesome. Try to watch the video. You can get some pearls from positioning and wire placement, all that stuff when you're there. Like and subscribe. It helps us out. And any other thoughts, Leland?
I'm going to be training for the 4-minute Jones. It's like the 4-minute mile.
You know what? You shouldn't even try, probably, because it's probably like impossible. So, I mean, I wouldn't even try.
Love it.
All right. If someone has beaten that record, send me a message. I would like to know.
I love how the camera turned to your tourniquet. That's awesome. Just for verification.
that was the rep videotaping. I was like, here, video this. I'm going to see how I can do. All right, so that'll wrap it up for this episode of Pod Patrol. Thanks for joining us with your host, Dr. Jeff Dykes.
Dr. Leland Jaffe. We'll see you later.
See you guys. See you guys next time.